At ASCO this year, we're presenting the results of Destiny Breast09, a randomized phase 3 study of T-DXd plus pertuzumab compared to taxane plus trastuzumab and pertuzumab for first-line treatment of patients with metastatic HER2-positive breast cancer. We know that about 15 to 20% of breast cancer is HER2 positive, and outcomes for patients with metastatic HER2 positive disease have dramatically evolved over the past few years since the introduction of T-DXd, which is currently established as a second-line standard of care based on the results of Destiny Breast03, where we saw an unprecedented 29-month progression-free survival. There's been a lot of interest in trying to move T-DXd into the frontline setting, particularly knowing that the current first-line standard of care, taxane plus trastuzumab and pertuzumab, has a progression-free survival of a little under 19 months. We also know, unfortunately, that about 1/3 of patients who start first-line treatment for metastatic HER2-positive disease are not able to go on to receive a second line of therapy, either due to deterioration in health or death. The Destiny Breast09 study was designed to really explore the efficacy of T-DXd in the upfront setting. Eligible patients were required to have metastatic HER2-positive breast cancer and could either have de novo metastatic disease or be at least 6 months out from completion of systemic therapy in the early disease setting. No prior systemic treatment for metastatic disease was allowed, with the exception of one prior line of endocrine therapy. Asymptomatic and active brain metastases were allowed. Patients were randomized 1:1:1 to receive T-DXd plus placebo, or to receive T-DXd plus pertuzumab, or to receive a taxane with choice of paclitaxel or docetaxel with trastuzumab and pertuzumab. For those patients randomized to the T-DXd arms, T-DXd was administered until disease progression. If T-DXd was discontinued due to toxicity, then trastuzumab could be added and was given alone in the T-DXd plus placebo arm, or was given with pertuzumab in the T-DXd plus pertuzumab arm. For those patients on THP, taxane was administered for a minimum of 6 cycles or until development of intolerable toxicity, at which at that point, patients were then shifted to receive trastuzumab plus pertuzumab. If patients had hormone receptor positive disease, then they could add endocrine therapy either after a minimum of 6 cycles of T-DXd or after discontinuation of taxane therapy. The primary endpoint was progression-free survival by blinded independent central review, comparing T-DXd and pertuzumab to THP and comparing T-DXd plus placebo to THP, but the two T-DXd arms were not powered to be compared to each other. At the time of this interim analysis, the T-DXd plus pertuzumab arm demonstrated superiority compared to THP, and these results are being presented. Here you can see the primary endpoint, progression-free survival by blinded independent central review, demonstrating a median progression-free survival for T-DXd and pertuzumab of 40.7 months compared to 26.9 months for THP, with a hazard ratio of 0.56 and a p-value of less than 0.0001, with an absolute difference of 13.8 months between the two arms. Here you can see the adverse events that were the most common for each of the arms. For T-DXd and pertuzumab, the most common adverse events included nausea, diarrhea, and neutropenia. And for THP, the most common adverse events included diarrhea, fatigue, and anemia. In conclusion, Destiny Breast09 is the first study in over a decade to demonstrate an improvement in outcomes across a broad population of patients with metastatic HER2-positive breast cancer in the first-line setting. The study demonstrated that T-DXd and pertuzumab had a statistically significant and clinically meaningful improvement in progression-free survival, with a median PFS of 40.7 months compared to 26.9 months, with a hazard ratio of 0.56 and a p-value less than 0.00001. This benefit was really seen across all subgroups of patients. We also saw that the median duration of response with T-DXd and pertuzumab, as well as the complete response rate and objective response rate, were numerically better for T-DXd and pertuzumab compared to THP. While overall survival data is very immature, it does suggest a positive trend favoring T-DXd and pertuzumab, which is also supported by an improvement in PFS2, which had a hazard ratio of 0.6. The safety data for T-DXd and pertuzumab were consistent with the known toxicity profiles of the individual treatments, suggesting no additive toxicities. And given these data, the combination of T-DXd and pertuzumab may represent a new first-line standard of care for patients with metastatic HER2-positive breast cancer. Thank you.